I have the pleasure of introducing Darlene Taylor from the University of BC, Okanagan. Dr. Darlene Taylor is an assistant professor in the School of Nursing at the University of British Columbia, Okanagan campus. She has a Bachelor's of Science in Nursing, a Master of Epidemiology, and a PhD in Public Health. She has expertise in evaluating public health interventions for HIV and other sexually transmitted infections, particularly among individuals who misuse substances, men who have sex with men, and people who experience homelessness. Her master's research involved evaluating the impact of HIV reporting by comparing the time from HIV infection to diagnosis using a sensitive, less sensitive testing algorithm. She has also been a team member on a large study evaluating the impact of diagnosing HIV during the acute phase in men who have sex with men. Darlene has conducted several systematic reviews related to sexual health. She has developed a psychometric instrument to assist nurses determine if their clients have capacity to consent for the care they are being offered. She has developed an instrument aimed at assisting clinicians counseling their clients about the probability of a false negative HIV test when testing during the window period. That's not the end of the bio yet. Darlene's approach to research.
I just threw out. Sorry, I just fired off.
Well, when you have lots of experience, it's great to mention all of it. Okay, so almost done. Darlene's approach to research is community-based action research and enjoys working with community agency to ensure research is conducted in a respectful way that does not further stigmatize populations that are considered by some as marginalized. Please welcome Darlene Taylor.
I got to pay more attention when people ask me to send them stuff. So I apologize for that long introduction. So I'm really happy to be partnering with Kim at Living Positive, and he's been able to introduce me to the partners that he has, and I'm part of the research committee with Living Positive. So we've been working together on some initiatives. So Kim has described to you really well some of the challenges involved in trying to offer services for guys who like guys in smaller settings where services just aren't available, and in interior health where services have actually been stripped away. So thanks very much for that sort of statistics part that I don't actually have to do. So there isn't really all that much research that has been done. So services, not only are services scarce in small urban and rural communities, but also there's also a dearth of research that's been done. So we really don't even know how effective services are for men who have sex with men in smaller areas, and whether or not you take an intervention that was developed in a larger urban setting and transplant it into a small community setting, and you know, does that even work? We don't know much about that at all. So I'm working with Kim and others to try and help sort that out, and to help sort of provide some of the empirical data to provide to the policymakers and decision makers around the services that are provided. So the geographic location and less tolerance to sexual diversity are major problems. So a lot of the barriers that men who have sex with men have in small communities are similar. It's going to sound familiar to you, but they're actually really magnified. And so some of it you'll go, yeah, well, we have that in the big city too, but it's actually greatly magnified. And so just to kind of forewarn you about that. So what we wanted to do was do a small pilot focus group to gather some information about what the experiences were that men who have sex with men have in interior health about accessing STI services, and especially in light of the fact that those services were actually taken away. And we wanted to know what were the barriers and facilitators that were involved in accessing STI services in small urban areas. So we did a focus group, and I have to confess, this is not a rigorous scientific study. It was a convenient sample. So we took people who were attending an event that Living Positive put on called The Gathering in Kelowna, and men were allowed to sign up for different workshops. And one of the workshops was a small focus group, and so we invited them to come and talk to us about their experiences with trying to access sexual health services in their communities. So we did a small demographic questionnaire, and then it was a small focus group that took about an hour, and it was a very structured guide, so it wasn't like we were trying to develop any new theory or anything. Each of the participants were given a study number because the focus group was audio recorded, and so the participant number allowed them to remain anonymous. And then we audio taped it and transcribed it, and then just looked at different themes that came out of it. So there were 6 men, which doesn't sound like a lot, but there was only 24 men that attended the event in total. So the ages ranged from 20 to 39, and only 4 of the 6 were from Interior Health. One of them was from the Vancouver Health Authority, and one was from the island. And the majority of them were Caucasian and had post-secondary education and were full-time. Most of them were anyway. 5 of them identified as being cisgendered, and all participants identified as either being gay, and 2 identified as being queer. All men identified as being out to their family or friends for more than a year, and all of them had access sexual health services within a year. So these were the general themes that came out of it. So we talked a lot about what it's like to access healthcare in general, not just sexual health, but how scarce healthcare, how hard it is to access any kind of healthcare. And then we talked a little bit about what the differences were about accessing care in small and compared to rural settings. We talked about where men go to get sexual health services. And one of the common themes was a concern of the poor amount of training that healthcare providers have regarding the sexual health needs and just sort of the sexual health activities that men who have sex with men have. And then there was a discussion around the negative and positive experiences people have had. So generally speaking, it's almost impossible to get a new family physician in the interior. It's similar here, but when you move farther away from the larger cities, then physicians are just in great demand. So here's just a quote from one of the people. A couple of my friends who were pregnant, they got a GP because they got a OBGYN who just kept them on as a patient. Some people are really lucky because they've had a family doctor since they were a child. But if you're moving from somewhere, it's really hard. If there is a new doctor that opens up, then people swarm them. So there's a statistic here that 15% of the population in British Columbia don't have a family physician. And I can tell you that me moving from a big city where I had to give up my family doctor to go to Kelowna, it's been quite an adventure trying to get a family physician. Sorry, I just got to catch up with my notes here. So again, another quote was, not only just with testing, like STI testing, but it's rural access to any sort of healthcare services. It's like Ashcroft and Lillooet. In those areas, they just shut down emergency hospitals. Acute care places, they just say, go drive 2 hours to Kamloops, because that's the nearest center. So I remember during the interview when I heard that, I thought, man, I wouldn't want to have a heart attack in Lillooet because you'd have to drive 2 hours to get some care. So I'm sure there must be some way to accommodate a heart attack, but I mean that's really how far people have to go. And I'm not sure, like some of you are coming from out of province, but Kelowna is actually the biggest city in the Interior Health, and it only has 145,000. So the smaller areas are very small, and healthcare accommodations are far and few between. And this slide shows pretty well, it really is, okay, you're driving along and you've got like 125 miles to get to your next clinic. And lots of times when it comes to your sexual health, you're a little bit reluctant, oh, do I want to go and put myself through that? And, it's hard enough just dealing with that issue anyway without having to deal with some of these large geographic barriers as well. And this in Kelowna, this is the one thing that concerns me the most. I either go to the Gospel Mission or Aurora or the Urban Health Outreach for the homeless people, because they're pretty much dealing with healthcare providers that really are open and inclusive about everyone. And so the Gospel Mission is like a soup kitchen. So you've got men who have sex with men that are going downtown to an area of town that predominantly serves impoverished people who, are dealing with addictions and are homeless. And you've got men who have sex with men that are choosing to go to those settings to get health care, because at least you've got some healthcare providers there that are somewhat open-minded. So in rural settings, people are much more conservative, and a lot of men don't want to disclose their sexual activities because the fear of stigma is very great. And many of them just sort of, they don't disclose to their healthcare providers. So there's a great need for places where they can go to get safe and expert advice around their sexual health. And so they find themselves going to like the Aurora. The Aurora clinic's good. It's actually not in this area that's at the heart of the impoverished area, but people going like to urban outreach, you're dealing with people that are mostly homeless. So it's a very awkward situation. Here's another quote. To book an STI test or an HIV test with an outreach nurse and I start asking them really hard questions about PrEP. And so this is kind of points to how creative some of the people are in trying to get like healthcare access to a healthcare provider that knows something. So the advice that they're being given is to just try and get in to get an STI test or an HIV test, and then start asking really hard questions about PrEP, about everything else, and they'll just automatically refer you to a doctor who actually has some expertise in the area. And then she'll be like, you're not a candidate for PrEP, but she'll pretty much do her best to find you a primary care provider from there. And so it just highlights the challenges. And Kim was talking about some people that will decide, okay, well, I don't want to have to deal with this in Kelowna or Kamloops or whatever. This quote, I don't have access or know anyone who could refer me to anyone who I would feel comfortable with being tested by. So Kamloops, it's quite close to Vancouver, and I would just go down there on the weekends anyway. But this is a picture of like, if somebody decided to do that this weekend, that's what they would have to do is kind of hope that the highway's not closed because of snow, and hope that the roads are safe enough so that they could actually get to Vancouver and get their sexual health services. So you can understand why people are reluctant to actually take care of themselves sexually, right? And then there's the whole thing about many of the healthcare providers having poor training. This is a conversation about concerns that physicians don't actually get proper training around sexual health in general when they're going through medical school, let alone sexual health related to different diverse sexualities, right? So it's like 20 minutes of their curriculum. Like doctors are in school for like 4 years. Well, there's one that they have to take. It's like a society and something or other. And they throw in a bunch of queer stuff and drug abuse and all that into one course. It's not enough. And like, they're also like, there should be some sort of aptitude testing or something like that. Like if healthcare providers aren't open-minded, then they shouldn't be able to be healthcare providers. And I don't know how you teach open-mindedness, but there's got to be some way to start screening out people who have like personality and aptitude to do better healthcare delivery because grades aren't enough. So there's a concern that physicians really are not, even general physicians, no matter where you are, really are not trained properly in how to handle sexuality issues. And then, like I mentioned, stigmatization. I know stigmatization is everywhere, but you know, in smaller communities, it can be pretty great. There's oftentimes people that are communities that are very highly religious, and there's just less tolerance towards sexual diversity. So this one person said, my doctor thinks it's unhealthy for me to be LGBT. And so, like, he thinks it's a choice. Like, you know, yeah, it's difficult to talk to my doctor about anything. And then I just really like this little quote that I found. This is not the name of a participant, so don't worry. I just found this. You know, when you're struggling, you think, oh my goodness, I just got exposed to HIV. What we don't need in the midst of a struggle is being shamed for just being human, right? That's the last thing that you want to feel. And then this other person wanted to explain a very common, what they thought was a common experience that men who have sex with men have, not understanding what anonymous sex is, and then shaming their patients for engaging in anonymous sex. How could you not know who you were sleeping with, and that sort of thing? And it's like, it's not just one person. Like, every single person, every guy you talk to has a story like that. And why isn't anything being done about it? Why are we being quiet about it, you know? And so it's this whole context of they're being treated like this, and yet they kind of feel like they don't have a way to stand up for themselves. There must be something. And so that there was a general sense throughout the whole focus group of what can we do about it? We need to tell people that this is happening to us, and how do we go about doing that? There were some really good ideas about positive experiences people had, and this is kind of funny one, but it was, you know, the whole idea around people. Am I okay for time? Okay. People wanting to be in an environment with a healthcare provider that made them feel comfortable, and perhaps even having a fun situation. So in terms of your question about attitude, it makes a huge difference. At the Kelowna Prick event, I saw a nurse who made me laugh so hard when I was getting tested. Like, I was getting a rectal swab and I was getting blood drawn and the whole shebang, and I was just laughing. I had such a good time, which, you know, it's hard to imagine. But really, honestly, if you've got someone that makes you feel comfortable enough while they're doing the busy activities that, you know, an SDI, nobody likes any of that kind of stuff, right? But, you know, if they can make you feel comfortable and make you laugh, then, you know, you're going to go back in 6 months to get a retest if you need to. And then this also was a really funny one. It was a discussion around this person's one of their first experience accessing sexual services. It was my first boyfriend, and he told me he was HIV positive. I lost my mind because I was from rural Nova Scotia. I went into a nurse in Montreal, and she sat me down, and she was eating popcorn. And she was offering me popcorn and asking me questions about rimming and sucking cock and using very, like, street language, and the whole time eating popcorn. And I thought, okay, you know, I'd probably go in for STI testing if that was kind of the experience I was getting, right? So one of the things that I wanted to find out from the participants was, okay, if you're a guy who likes guys, is it your preference that you want to have care delivered to you, or you want a provider who has that same lived experience? So I kind of wanted to get to the bottom of that. And there was actually diverse opinions about that. But this participant said, so I'm tired of straight people providing me with health care. I'm just kind of over it. Well, I think it's because my community has always given back to me. I've always been able to, as a gay person, the gay community has always provided me with what I sort of needed, especially in my adult life. And I think they should be able to provide me with the health care too, because they're the ones that really get it, right? They're the ones that really get it. So you don't have to feel unsafe about saying what it is that you're concerned about. But there were various opinions about that, and the other side of that was it doesn't really matter whether or not the person is a guy that likes guys, as long as they have the right attitude, that they have the expertise. There was also a sense that men who have sex with men in those communities don't really know where the services are. There was a sense that they're not really advertised all that well. And you add that to a community where guys don't really have a place to congregate socially. So there aren't gay bars, there aren't different places where guys who like guys would congregate socially and just sort of support one another. And so there was a desire to really have a way to network better so that they can support one another and let each other know how far they have to go to get their test. And I just wanted to leave you with this final quote, which I think sums it up pretty clearly. I think there's definitely a lot of opportunities for guys in the interior to talk about their experiences with healthcare providers and the sex that they're having in an anonymous way, to be able to submit their stories online and really have stories out there that really show the disparity in healthcare services, not just for gay men, but for everybody. There's many stories out there that just horror stories about guys walking into different clinics and different offices and dealing with different nurses and just getting completely unfair treatment. And I think that if we can start sharing these stories, it can really help, it can be really empowering, and we'll see a lot of change because it's quite frankly just inappropriate in a lot of situations. And so there was a real desire to get the stories out and let people know that this is not okay, the way that they're being treated. So in summary, healthcare services in general are difficult in small urban and rural communities. Stigmatization and shaming by providers is prevalent, but it's not okay. The MSM in small urban and rural communities go to great lengths to try and utilize creative ways to get the appropriate safe services that they want. There's a great need for MSM to have places where they can socialize and support one another, and there's a desire to have their stories told. That's all.